So I just wanted to thank everybody for joining this evening's talk. We've been really excited about it to have Dr. Oakley on. So yeah, it's going to be a great talk this evening. I'll introduce myself. My name's Jyoti. I'm with UTIVA. Of course, you've seen all of the emails that I've been sending out leading up to the talk. We also have Feroz here, who is the sales manager for the UTIVA or the Zio+ team. And before we move into the presentation, I wanted to go over some quick housekeeping. So in terms of the agenda, we'll do some introductions. Dr. Oakley will then move into her presentations for about 40 minutes, and then we'll leave a solid 20 minutes for all your questions and answers, for all of your questions. So make sure you add your questions into the chat or the Q&A throughout the presentation. We'll be logging them in the background. So no need to wait until the end, just throw them in as soon as they come up. And after the Q&A, we will then move into the live raffle. So make sure that you're actually here. If your name's called, you're going to need to actually say hello in the chat to claim your prize. And then after that, if you're interested in any to learn more about UTIVA, we will go through a quick 5-minute presentation and hang on for any questions that you have. Okay. So with that, I will introduce our presenter for the evening, Dr. Susan Oakley, who is a fellowship-trained, double board-certified surgeon in private practice for 10 years with St. Elizabeth Physicians in Northern Kentucky, and the greater Cincinnati area. Dr. Oakley served as the inaugural chair of the St. Elizabeth Healthcare Women's Health Institute, while also serving on the board of directors for 8 years. Currently, Dr. Oakley is on the Leadership Council for Oncology Disease Management Teams at the St. Elizabeth Healthcare Cancer Hospital. Dr. Oakley is married to an engineer and have 2 young daughters who love piano, golf, and dance. In Dr. Oakley's spare time, she co-hosts a weekly podcast called The Lady Bod. She is from Pinehurst, North Carolina, and still a proud Tar Heel, getting home often in order to see her family. Thank you so much, Dr. Oakley, for joining us this evening.
Thanks, Jyoti. I appreciate it. Were there any other introductions that you needed to make?
No, that's it. We're good to go.
Okay. Well, welcome everyone. I'm so glad you're all here. And of course, thank you to the Zio+ and UTIVA team for allowing us to have this riveting conversation tonight about recurrent urinary tract infections. I certainly appreciate that introduction. It makes me sound so much more glamorous than I really am. But just in short, I never intended to be a pelvic surgeon. Y'all should know that my background is actually in musical theater, which is probably where I get the bug to do the weekly podcast and sort of crazy TikTok videos. But my father is a mission surgeon and took me with him on a trip. And ever since I worked on fistulas in Ethiopia, I decided I wanted to become a urogynecologist and pelvic reconstructive surgeon and have that sort of ultimate focus on women's healthcare. And so this topic tonight about urinary tract infections can sometimes, unfortunately, be the bane of our existence as a surgeon, but it's such an important topic to our women and something that's really making a lot of strides and progress in research and in women's healthcare in general. It plagues our patients, right? So we really need to figure out great ways to prevent urinary tract infections. And that's really my goal today, is to kind of give you the basics. But please do keep that in the back of your brain that I am a mission doctor, often doing work abroad. And so I'm pretty casual. I like to call myself a cowgirl. I like to freewheel it sometimes. So I want to sprinkle all of the medical facts today with just some practicality. I appreciate all of your questions. And like Jyoti said, put those in the chat so that we can get to all of those questions at the end of this presentation. So again, welcome. I know you know your UTI Facts 101, but we are talking about UTIs or urinary tract infections this evening. And these infections really can affect any part of the urologic tract, right? So the bladder, the kidneys, the urethra. I find oftentimes really just focusing our patients in on the correct terminology helps them to better understand our plan for evaluation and management. And ultimately, just remember that, as you can see on your screen, UTIs or infections are caused by bacteria typically, but they can be caused by other things. So we can't rule out those other things when discussing and evaluating this with our patients. And there are several ways to evaluate it, and then several ways to prevent and treat it. So those are your key facts, your 101 to start out today. I do have some financial disclosures, so definitely want to put those up on the screen for your reference. And again, like Jyoti said, I am a double board certified female pelvic medicine and reconstructive surgeon. You can be an OBGYN who goes into this 3-year fellowship training in America, or a urologist. So I have a background as an OBGYN. All right, so our objectives today, we just want to reinforce the standard definition, right? I mean, y'all know how many times have our patients called us and said, Dr. Oakley, I have a UTI. Give me what I want. Order those antibiotics. I need to feel better soon, and I know my own body. That is not the standard definition of a UTI, right? So sometimes with my patients, I'll say, oh, so we just diagnose our own cancer without a biopsy and just ask for the chemo we want. So that's an aggressive analogy, but sometimes putting it in that sort of perspective for our patients reminds them that we are care providers and we want to have due diligence and make the appropriate diagnosis before we go down the rabbit hole of potentially unnecessary treatments, right? So we really want to understand the definition before we can fully understand the evaluation and then implement a practical prevention plan. So y'all probably already know all the epidemiology and background of urinary tract infections, but it's a good place to start if you don't know. So just a few key points. Certainly don't want to bore y'all tonight because I know everybody's itching to get to the facts of prevention, but epidemiology really is critical to review. So as you can see on your screen, the prevalence of urinary tract infections, it increases with age, right? So if you are like me and you are a post-menopausal woman and, being close to 50 and certainly women over 65, we certainly see a prevalence at 20% versus the general overall population having a prevalence of UTIs around 10 to 11%. And this is a critical point in evaluating and sort of managing these patients, right? Are we having premenopausal issues or postmenopausal issues? And we really have to be mindful of the fact that the prevalence of infections does increase with age in our women. And I think it's staggering, y'all, to see that over half of women will have at least one infection in their lifetime and then be immediately reinfected at a 27% rate within that first 6 months. And so this is really where we start to hone in on that recurrence of UTIs and how annoying and frustrating it can be for women and how we prevent it, right? Because yet again, here's your patient calling you, demanding antibiotics, saying she knows how she feels and she just had this infection 3 months ago. And did you not treat it long enough? She wants double the dose and double the amount of time in antibiotics. And so we have an obligation as care providers to really re-educate our patients on the epidemiology and use that standard definition of recurrent UTI as a point of reference. I do find in my practice, it really helps me to mitigate expectations, right? Which is really important in healthcare. So more facts, y'all already know that in these postmenopausal women, the source of that infection is variable, right? Do you have someone who has multiple comorbidities? Is she hospitalized? Is she already on a catheter for some other reason? Does she have spina bifida, cerebral palsy, some sort of other back injury, motor vehicle accident, or trauma to her spinal cord that has put her at an even increased risk of UTI above the normal postmenopausal woman? I think ultimately, another fact that we really need to share with our patients is that 85% of these infections, no matter what your risk, are going to be caused by E. coli. I think a lot of our women, they get scared, right? They're like, oh, Dr. Oakley, it said E. coli. I swear I'm clean. I wipe front to back. How is it that I have poop in my urine? And we really need to remind our patients that this is kind of the normal flora and fauna, right? Like you have E. coli in your gut and butt. I got E. coli in my gut and butt. Do I want it to crawl from the back to the front hole? I don't. But we still have to calm our patients down and remind them that the majority of E. coli is just kind of naturally in us, and the majority of UTIs are caused by that E. coli that's sitting there. The better job we can do at educating our patients, right? Which this talk isn't taking that long tonight, so it doesn't take that long to discuss it with your patients, but that can save us billions of dollars. And I know we have listeners outside of the United States, so I apologize that I failed to include those statistics financially, but I think in most countries we can say that recurrent urinary tract infections absorbs a lot of time and money with office visits and testing and treatments. So I don't know if the animation worked on this slide, so I apologize. But either way, I think just reviewing that the top causes of UTIs are E. coli or UPEC and Klebsiella, sometimes Proteus as well, and just realizing that there is a difference between that sort of run-of-the-mill recurrent UTI patient and then more complicated patients like we discussed a moment ago is a really important fact. And so I'd like to focus really on the sort of run-of-the-mill recurrent urinary tract infections today, but I still welcome questions about the more complicated patients. All right, so I stole this slide from the WHO, but the World Health Organization is a great resource. And the slide's a little busy, but I think we can all understand that the cute little worms on the screen are not tampons. They are not sperm. These are our bacteria, and mapping the bacteria and introduction of antibiotics within our culture and society over time really points to a very disturbing fact, which is that the World Health Organization has identified that resistance to antibiotics is really a top 10 global healthcare issue. Right? So this idea that patients can just ask for a Z-Pak when they have a cold or ask for an antibiotic when they think they have a UTI and get it is really promoting a very bad problem with a negative impact, right, on healthcare and progress in healthcare. So we diagnose really almost 3 million types of these infections annually that have some sense of antibiotic resistance. And I think that fact is staggering, y'all, staggering. And I hear y'all, I know you are sitting there in your chair watching this and you're thinking, God, Dr. Oakley, it's so much easier to just prescribe that antibiotic for the patient so she is happy and leaves me alone. And I agree with you, I do. But I think if we just take those extra 5 minutes, again, to re-educate and point these facts out to our patients, that goes a long way with helping them through sort of, again, the evaluation and management of recurrent UTIs. Y'all are probably aware that antibiotic overuse can create really more devastating healthcare issues and cost to the patient and the system, like C. diff, right? So Clostridium difficile infections can prolong hospitalization and absorb a lot of time and money. And then there is good research in the last year to say that chronic antibiotic use can increase one's risk of colon cancer. So these are real facts that I like to point out to my patients. And I think, again, we have to change our culture medically, right, to change the culture of what our patients are perceiving and demanding from us. So yeah, we already said this, antibiotics are often requested, but studies show an increased cost and healthcare issue to the patient and the system down the road. And you can see there just some superficial stats, again, not hard and fast cost in the United States by any means, excuse me. But if you compare the cost of conservative therapy or UTI prevention with the cost of a potential antibiotic regimen that might lead to C. diff and hospitalization, I think the answer is clear, right? Prevention is key. I'll speak for Americans. Americans don't necessarily like prevention, right? We're kind of that group in the world that likes to just hit it hard and fast and kind of play it loose and easy, and then ask someone to fix it later. Now that's a general, harsh generalization, but I do wish more Americans focused on prevention, and that's what I'm going to focus on today. So picture this, right? You are a young married woman in the 1850s, okay? And all of a sudden you get out of bed to go pee in your chamber pot, and you got the stinging, the burning, the urgency, the frequency, and it's 1850. You don't really know what's going on. You just know it hurts, and it might even get to the point where you can't urinate at all, and you are in retention. Now, with a good immune system, 50% of these infections can actually just go away, right? If you have good immunity. But think about nutrition in 200 years ago, and other obviously social issues at the time. And this woman may have actually died from what was an uncomplicated urinary tract infection, right? Before the true invention of antibiotics. So urinary tract infections, they scare people, right? They probably scared people in 1850, like this lady, and they're still scaring women to this day. So again, it's a very frustrating thing that 50% of women will get an infection in their lifetime, and 12% of men will as well. So let me see. I'm thinking as far as this UTI, she could have had symptoms, again, of fever, chills, cloudy, dark urine, inability to void. And yet when y'all look at this, y'all do understand that these signs and symptoms are still not a clear diagnosis of a urinary tract infection, right? So it's really important to get that conversation going with the patient, meaning what might have potentially caused your signs and symptoms. Is this really a urinary tract infection? Is it something else like overactive bladder plus atrophy of tissue? Is it painful bladder syndrome? So again, did she have recent sexual activity? Is she on birth control? Does she have diabetes? Is she postmenopausal? What's her perineal hygiene like? These are really, really important risk factors to assess when trying to help this patient through her symptoms and diagnose that urinary tract infection. So we all know that part of the diagnosis has to be made with a urine culture, right? And so a lot of offices have a practice of sort of a midstream urine culture where they ask the woman to start peeing and put a cup under her pee hole. Now, I don't know about y'all, but if you're a woman like me and you have tried to hover over a public toilet seat in a doctor's office or elsewhere and start to pee, right? Start to pee, but maybe you're postmenopausal like me and you have no control over your bladder. And you're like, now how am I supposed to pee? And aim for this little cup. And there is pee going everywhere, right? You got it all over your hand. It's no wonder that so many of these cultures that we need to make that diagnosis of a urinary tract infection come back as contaminated. We need to see bacteria in that culture. My office has a very strict practice of obtaining these cultures by straight catheterization. That doesn't mean that you have to adopt that rule or practice, but again, we like to have a standard of care and remain very strict about this. The way I explain it to my patients is if we find a contaminated culture, that's a negative culture. If there was meant to be urinary bacteria, we would have found it. The fact that it's contaminated by vaginal flora and fauna is a negative urine culture, right? So we may not see E. coli every time it has positive bacteria in a truly positive culture. But again, most of the time, 85% of the time, we are going to find that E. coli. And so we straight cath our patients to get that culture, to find that bacteria, and assess that culture for sensitivities or antibiotic susceptibility. So it's really critical, in my opinion, to avoid that crazy clean catch that no reasonable woman can do if you have ever tried to do it yourself. And so, why is E. coli so common as part of the pathogenesis for urinary tract infections? Well, y'all know when you look at E. coli, it looks like a furry, hairy little bug under the microscope, and it has this pili or hook, right? And that's what kind of gives it its fuzzy, hairy, furry sort of look or personality. And it makes it, maybe you think it's cute, but it makes it really adaptable to the lining of our urothelium and urinary tract, right? Those little tiny peline hooks are just like little tiny mountain climbers, right? They're just crawling from the butt towards the pee hole, and they're just getting all up in there. And because they have this adherence to the lining of the bladder, they kind of hang around, right? And so these FemH or Fem hooks are really not aggressive, but just, again, well adapted to the urothelial lining. And that's why we see a lot of E. coli in the pathogenesis. So now that we know the general symptoms, right? It can be fever or not, chills or not, urinary urgency or frequency, burning, doesn't have to have burning, right? So we've got the symptomatology, which again was probably an uncomplicated UTI for a lot of these women, pre-antibiotic intervention. So we got a good handle on the signs and symptoms. We know we need a culture. We know we're looking for E. coli. We know why E. coli is so prevalent in the urine. But we still need that positive result, right? We need that objective data. And so y'all know the definition of a recurrent urinary tract infection is 2 of those positive cultures, preferably catheterized in my office, in my practice within 6 months, or 3 within a 12-month time frame. We really want these to, again, be symptomatic, right? Otherwise, you're just getting sort of that asymptomatic bacteria, which has no indication for treatment. And so we want it to have the signs and symptoms we just discussed and be a medically diagnosed urinary tract infection. So we got to have the symptoms, we have to have the objective data. And a lot of times I'll get referrals as a specialist where the cultures are clean catch. As long as they're positive, and there's been 2 in the last 6 months, I've got my diagnosis. So where do I go from here? What is my mind thinking when I get all these referrals? I'm immediately going to rule out fistula, stone, any sort of birth defect or congenital anomaly, malignancy, just by history and physical exam in the office, right? So I think a lot of us are well versed at doing that, but it's still important we be mindful of that differential diagnosis because we certainly don't want to overlook anything. So basically, I look at my patients. I talk to my patients. I talk to them before I get their pants off, right? That's really important. And I just say, listen, Barb, right? Because everybody is named Barb in my office. I say, listen, Barb, there are only 4 reasons that we get UTIs, truly, honestly. Number 1, diet. And that may be hard for a lot of us to hear tonight, but diet, number 1. Number 2, menopausal status or atrophy of tissue, even if you're premenopausal. Number 3, an inability to empty, right? And that can be caused from any of the things that you just saw on this slide here. And number 4, wetness, right? It's like, duh, if any of us are parents and we've got our kiddos, if they sit in that diaper all day, they're going to get an infection, whether it's a yeast infection or a UTI. So if we sit in pads and diapers all day, no matter how good we think we are at being hygienic and changing these pads and diapers from our fecal and urinary incontinence, it's still a potential source of wetness and infection, right? So those are the big 4. Like, I don't want y'all to overthink this tonight. Everything on the screen right now is totally applicable to your evaluation. But do this evaluation while you are thinking of the big 4. Does this lady come in drinking a Mountain Dew? Where I am in Kentucky, the answer is probably yes. And does she drink 6 of them a day? Again, the answer is probably yes. If she would cut out coffee, tea, soda, it would make a world of difference. Also keeping that optimal diabetic A1C under 6. Again, not rocket science. The second cause we said was atrophy of the tissues for females experience recurring UTIs. And you can see atrophy of the tissue in a 20-year-old with Crohn's disease. You can see atrophy of the tissue in someone like my 8-year-old who was born with labial agglutination, right? You can see atrophy of tissue in someone like me who's going through menopause, or someone who's going through radiation for uterine cancer or cervical cancer, right? So it's not really an age-dependent sort of menopause conversation. It's really just atrophy. Number 3, retention. Are they retaining? Because as you see here on the screen, they had recent surgery, they had a sling, they had a pee hole sling, and it's too tight and they're in retention. Do they have a childhood condition? Do they have constipation, so their pelvic floor is contracted? Do they have a big old vagina prolapse hanging out and blocking their urethra or pee hole? You know, men can have an enlarged prostate blocking their urethra or pee hole. So we can have things that block and cause retention as well. And then finally, we said leakage or incontinence of urine and feces. So the big 4, don't forget them. If you only remember that one fact tonight, remember those big 4 and be willing and able to say it to your patients. So I think if you've gone over the big 4 with your patients, then imaging, in my opinion, is really necessary for several reasons. 98% of the time, you're going to find normal kidneys on CAT scan or CT scan, and you're going to find a normal bladder on bladder cystoscopy. But these 2 things up on the screen, I think, are still very important because you're really seeking that 2% that's going to have some sort of visible issue that potentially, as a surgeon like me, you may be able to remove and help. Have they had a mesh sling, and do you see it on cysto? Can you remove it? As I did today in the operating room. So a referral for UTIs, found a sling that someone had put in 20 years ago, and it was just transecting her urethra. I firmly believe that by removing that in the operating room today, I've really mitigated her UTI risk. So imaging is critical, even though you may only find something in 2%. So the second key point tonight for y'all is be willing to talk about the 4 etiologies. And I realize there are more, but those are my 4 big ones that I always bring up with patients because I need their commitment to diet and improving atrophy status, improving retention and wetness, right? And then standardize your imaging. Just say, hey, you've been referred to me with recurrent UTI. I'm not going to waste your time, Miss Barb. Let's just go ahead and get you in for a CT scan of your kidneys and a scope of your bladder. I mean, this is standard, it is practical, and it just really helps the efficiency of your practice. And I really think it reassures patients that you are doing the same thing for each and every one of them, like you would do for your children as a parent. And so then after we discuss the big 4 and do our imaging, and maybe it's totally normal, and we hope it is, right? Prevention's key. Okay, so here's that sort of third key point of tonight's webinar. You want to always remind your patients when it comes to diet, no coffee, no tea, no soda, and make sure they are drinking that 64 ounces of water a day or whatever y'all convert it to in milliliters. Sorry, I don't have my milliliters facts, but 8 bottles of water a day and an appropriate diet with an optimal A1C under 6. So again, that healthy intake with your diet and liquids. Some other sort of behavioral modifications to go with that main etiology of recurrent UTIs is just making sure that you don't sit in a bathtub with sort of crazy glow in the dark strawberry scented, salts and stuff every night, even though that may feel really good. You want that shower to rinse things off, and the use of a peri bottle or a spray bottle or bidet are always fantastic to utilize in the restroom. And then for women, wiping front to back, peeing before and after intimacy, and then avoiding a lot of irritants to the pee hole, right? So I always tell my patients, easy rule for y'all to remember tonight, right? Only do to your pelvic area, right? Only do to your pee hole and vagina hole what you would do to your baby girl's pee hole and vagina hole. As the mother of daughters, I would never scrub my child's vagina with a washcloth or a loofah. So why would I do that to me? I would never douche my child. So why would I do that to me? I would never spritz perfume on my vagina down there. So why do that to my child? So I think that's a really easy concept for a lot of women to hear and adhere to. So just that simple rule of, would you do it to your baby girl's vagina? If not, don't do it to yours. So simple prevention. Now let's talk about etiology number 2, right? So the big four. And the second was atrophy, regardless of menopausal status. There's been a lot of testing on estrogens, and any sort of topical estrogen has been proven to reduce urinary tract infections. As a matter of fact, it's the main recommended prevention by the American College of Obstetricians and Gynecologists. Systemic estrogens like pills and patches, not effective in that realm, although they might be good for other systemic menopausal symptoms. But really topicals are going to be your go-to for preventing UTIs. So being on sort of the clinical board for our cancer center, all of our oncologists are supportive of the use of these topical estrogens in our active breast cancer patients. The research is very clear that this is ultimately safe and effective. However, I hope y'all know how to use it, right? So do not dispense an applicator to your patients. No one needs to get a big old tampon applicator and plunge a bunch of estrogen up in their vagina where it's unnecessary. So if we're preventing urinary tract infections, they should take these topical estrogen creams and dispense about a blueberry size amount onto the fingertip, and make sure to really just rub it at the opening of the vagina. So spreading the lips and rubbing it right at the urethral meatus, right at the pee hole vagina hole opening. And that's where it's most effective. I do have an advantage over some of y'all tonight in that I use this every night. And so it's really easy for me to converse with my patients and say, hey, I apply this every night and I will till the day I die. And when I do die, throw it in the coffin because I'm taking it with me. It's magic. But I think that's why it's one of the top recommended ways to prevent UTIs by the ACOG. So we've got behavioral modifications and watching your diet to sort of counteract the main etiology of recurrent UTIs. We've got estrogen cream as a way to mitigate that atrophy of the tissue, regardless of the age of the woman. And again, this is something I used on my 8-year-old when she was born, and I use in my breast cancer patients, so it's very safe. And then, we're going to get into other ways to prevent urinary tract infections. But obviously, we want to give credit to UTIVA tonight. Again, I think I have an advantage because I actually do use this product. I talk about it all the time, but I'm not a Kardashian. I don't just say I use it, and not really. I absolutely use the UTIVA line of products. And so I think the team tonight is going to go over this in more detail, but remember a moment ago when we talked about E. coli causing 85% of recurrent urinary tract infections. Well, there's a picture of it there on the left side of your screen. So this sort of hairy, furry bacteria with the pili, or little projections and appendages, loves to attach to the urothelium and urinary tract wall, right? Well, when you are able to take a pack, which has a concentration over 35 milligrams, and this particular brand UTIVA has 36, which is great, then that's almost like dusting the bacteria and taking away its sticky power, right? So these PACs do a great job of sticking to the hair projections, so the hair projections can't stick to the inside of your bladder. Again, don't overthink it, not rocket science. Sometimes where I am in the South, I describe it to patients like when we make fried chicken, right? So a terrible analogy, but when we have to sort of dust it in the flour, it takes away the stickiness of the chicken. So then we can dump it in a pan of hot oil and have it fry up really crisp and nicely. It doesn't stick. So terrible analogy, I know, but that's the thought process. Like, we're taking away its sticky factor. And that's how PACs really work. So it's a genius concept, but not all cranberry supplements are the same, right? We don't want our patients to just chew cranberries. We don't want our patients to just drink a bunch of cranberry juice, right? Because that's giving them an unnecessary amount of additional sugars in their diet, which is not helpful and gets back to that main etiology of poor diet, right? As a cause for UTIs. So the other point that I think is really important is that a lot of cranberry products can have some vitamin K, which may interact with blood thinners, which a lot of our menopausal women are on, right? So UTIVA's line of PACs has removed all of that so that it's safer for our patients to take. Some of those facts that we just mentioned, you can see here, but also on the screen is the dosing. And so personally, I'll take one every day. I will tell my patients who truly feel like sex is a trigger for their urinary tract infections to take 2 before and after that act of intimacy. Now, make sure your patients know they don't have to like hop off, right? And go like running to the bathroom and sorry, honey, I got to go take my packs. I think taking them within a reasonable amount of time associated with the act of intimacy is okay, right? So no hard and fast rule here, but we do recommend 2 tablets with the act of intimacy if they feel that's a trigger for them. But typically, I just tell my patients once a day, and that I think is the most appropriate. Currently, I don't know if y'all are Amazon Prime fans, and this is going off script for a minute. Participants, I apologize, but it is Prime Deal Days. And I actually ship UTIVA from Amazon. And right now, I don't know if the team tonight wants to agree or disagree, but I think it's only like $30 for a 1-month supply on the Amazon Prime Day, today and tomorrow. So it's a pretty big deal. Also, I'm sure the team tonight can tell y'all other ways to discount it for your patients. I know for us, we have reached out to the company to supply us with sort of a QR code that our patients can scan for discounts throughout the year when they order these products. But certainly a product that is very much encouraged. So yeah, I'm a big fan. I take it daily. You can see compared to other brands and that are offered on the market for similar prices for self-purchase online, that UTIVA it has all the ingredients that our patients need to prevent those recurrent urinary tract infections. So it's pretty magical. I love it and I use it. But there are other ways that patients might want to prevent UTIs that don't involve spending money, even with the good Prime Day deals. And one of those is D-mannose. It's been around for a billion years, and it's just a super large sugar, and helps. I know it sounds counterintuitive, but it definitely helps to prevent urinary tract infections. There's really no standard dosing. I think most patients are going to take a 500 milligram capsule twice a day, up to 4 times a day. So they're getting anywhere from 1 to 2 grams orally. But again, this has traditionally been a less expensive option and one that patients can find over the counter at most pharmacies. I know UTIVA offers a D-mannose version as well, and I think they'll mention a little bit of that later this evening. Probiotics have some loose research. So if you take an oral probiotic, we're certainly not advocating that you shove a bunch of yogurt up your hoo-ha. So when you have patients that say they do that, please tell them to stop. Lord Jesus, tell them to stop. But a daily generic probiotic or prebiotic can certainly provide some preventative measures, although not my favorite, just practically in my practice. I've had patients ask about pre-leaf and any of these over-the-counter self-purchase pro and prebiotics, again, I think are reasonable because they're not really harming the patient and they may help, although no statistically significant evidence. I think one of my favorite preventions is really geared towards that third etiology, and that's retention of urine. So how can we release that retention if they have a fairly normal pelvic exam? We do that through pelvic floor physical therapy. And so I am very blessed to have 8 specialized pelvic physical therapists in my practice. And they are really wonderful teaching our women how to empty well and sort of do timed voiding. They go through their diet in detail and the need to add vaginal estrogen cream. So they're really going through those conservative measures for me. As a surgeon, I may not have all the time to do that. So I really lean on my pelvic floor physical therapy team, as should y'all. And then finally, my least favorite way to prevent UTIs would be antibiotics. Again, I think the whole goal tonight is how do we get our patients off of the antibiotic train, right? We have way too much resistance. It's costing us time, money, and it's a negative impact to our healthcare. Antibiotics can cause C. diff and an increased risk in colon cancer. So again, how do we get our patients to focus on the big 4 etiologies, which are all really conservative, easy ways to reduce these recurrent urinary tract infections. But that being said, you still may want to utilize antibiotics in your practice, and you should have the autonomy and every right to do so. So a lot of times we would recommend oral antibiotics, and that can be taken 1 tablet post-intimacy, or just a low dose of macrodantin or nitrofurantoin nightly. And we'll do that for just a short 6-month course. I always tell my patients, it's like getting the cobwebs out, right? We're just going to clear the air. You're going to do this nightly for 6 months if you've tried everything else. And let's see if we can just kind of start over with that flora and fauna and pH balance. And then there's this idea of self-start. I really am not a fan of that, but I think a lot of care providers love to just keep refills at the pharmacy for their patient and have the patient self-start a course of nitrofurantoin or sulfa-based products if they feel they have UTI symptoms. I have a lot of patients that say, I'm going on vacation. Can I take something with me just in case? And I am very tough, and I do say no. So I always get back to the big 4, and I say, if you are drinking your water, avoiding coffee, tea, and soda, optimizing your sugar levels, using your estrogen cream nightly, taking your UTIVA pack supplement every day, and we have done physical therapy to eradicate your incontinence, then there should be no need for a just in case self-start antibiotic on your trip to Maui. But always be mindful again of overuse of antibiotics before you decide to go down this prevention path number 5. So
hey, Dr. Oakley.
Yeah, I was gonna say I've been trying to talk fast. Yes.
So sorry to interrupt.
Go.
We're running, just a few more minutes, like maybe 3 to 4 more minutes.
This is it. I mean, I don't even have to talk. I think we really did a good job of going through sort of those 4 main etiologies. And again, diet, estrogen cream, pelvic floor physical therapy, which is applicable to our pre-menopausal and our post-menopausal case study. So just really quickly, if you have a young woman, she has completed childbearing and denies any red flags, but has classic signs and symptoms of a UTI with a fairly normal exam and a previously positive culture, this is probably a recurrent UTI patient. So what you do next is prove it with a urine culture, preferably straight cath, and wait for the result 72 hours later. Treat it accordingly, but always remind that woman that we need CT scan imaging of her kidneys, a scope of her bladder to rule out other structural anomalies, and to focus on those big 4. And that can include estrogen cream, even though she's 35. There's no reason she cannot use estrogen cream and UTIVA to prevent another UTI, since we know she is at that 27% risk for another UTI within 6 months. Case study number 2 is that 75-year-old. She's had a couple C-sections, so she probably is having a lot of urgency and frequency from her overactive bladder, but she's had so many positive cultures in the last 6 months. She feels sex is a trigger, and she's had a history of breast cancer. You find normal stuff on your exam. So can you still use estrogen cream? Absolutely. Don't be shy. So if she has a normal post-void residual and she is emptying very well and exam is normal, again, the big 4, lots of water, no coffee, tea, or soda, estrogen cream every single night, pelvic floor physical therapy to help keep her empty and to ask her about urinary incontinence, and if she has overactive bladder or urge incontinence, to treat it so she's not wet all the time. So that's it. These are my final thoughts. Make sure you are making the right diagnosis. You're choosing the right drug and the right dose and the right duration based on your culture. And de-escalation, right? Making sure you remind your patient of the big four, reassure her, do appropriate standard imaging, and be fair and consistent with all of your patients practically, right, in your practice. And then focus on those big four. So y'all are awesome. I can't wait to hear what the questions are. I hope I kept y'all engaged tonight. So what you got? Anything?
Okay, yeah. Oh, yeah. We have a ton of questions. So let's see how many we get through, like over 40 or 50, I think. Obviously, we're not going to get through all of those.
Okay. All right, good.
But yeah, let's see what we can do. So question number one, do you change your treatment, duration, etc., for a lower bacterial load, like 30,000, so not the greater than 100,000 that we typically see?
Yeah, great question. So typically I will not even treat it at 30,000. Again, I still have to remind myself I need signs and symptoms and a medically diagnosed UTI, which is 100,000 colonies, right? 10 to the fifth. So some of you may disagree with that practice, but if there are no red flags and my patient is medically stable, then I will not treat it. That is on the assumption that all my new patients, regardless of their consult, get a urine culture. Now, if they are specifically for recurrent urinary tract infections, I will treat that at 30,000 colonies, and I do not adjust my dose or duration. If it is susceptible to nitrofurantoin, then they will still get that normal full regimen, which is typically 100 milligrams twice a day for 5 days. Bactrim double strength twice a day for 3 to 5 days. A lot of people still do Cipro regardless of the black box warning, and that would be a 3-day course of Cipro as well, or Monurol, otherwise known as fosfomycin, which is a one-time powder sachet. So those are your treatments, and they should not vary even if colony count is low. Great question.
Thank you. So next question here, you may have, I think you did cover this a bit, but maybe it'd be good just to reemphasize. Is there a place for treating asymptomatic bacteriuria, especially in pregnant women?
Yeah, so great question. And then tonight was not to focus on pregnant women, but there is some good research to support treating that. As we know, an undiagnosed UTI can become pyelonephritis in pregnancy, which could lead to preterm labor and delivery, things we want to prevent. So yeah, reasonable at their sort of checkup, if you find that bacteriuria, to offer them treatment, since there's research to support treating it, but also not treating it. So I think discussing it and offering it is reasonable. Great question.
So how do you best manage almost end stage 6 dementia patients getting incontinent when UTI hits, particularly men? I mean, I don't think this is your primary patient population, but do you have any insight here?
So I just want to make sure I understand the question clearly. An end-stage dementia patient with incontinence and recurrent urinary tract infections?
Yeah, so they're getting, yeah, how would you best manage, these UTIs, particularly in men?
Yeah, so I still am going to lean back on my big four. If there's family or nursing staff involved, depending on their living arrangements, still focusing on the hydration, because dilution is always the solution to pollution. Making sure that, again, depending on the nursing staff or involvement of family, application of estrogen cream, if ever possible, and sometimes it's not with dementia. And then the incontinence, as long as they have a normal post-void residual, then I will entertain the idea of a beta agonist like mirabegron or Myrbetriq or Gemtesa in the United States versus an anticholinergic like oxybutynin because of their dementia status. But I still implant a lot of sacral neurostimulators for these dementia patients because I find that can prove they have retention on top of the incontinence. And if I can improve both of those, I generally reduce the risk of recurrent urinary tract infections without the overuse of antibiotics. I realize I'm giving a talk for UTIVA tonight, so please don't misinterpret this statement, but I always recommend a daily UTIVA pack supplement. Menopausal or not, dementia or not, incontinence or not. I think there's just a lot of goodness to be gained from preventing the adherence of bacteria and maintaining a better sort of pH balance. So that's how I would approach that end-stage dementia patient with incontinence and UTI.
Okay, awesome. Dr. Oakley, can you hear me well?
I can.
Sure.
Oh, absolutely. Sorry. Yes.
Awesome. So next question here, it's a bit of a long one, but I think it's a good one. So if you strongly suspect a fistula in a postmenopausal woman with recurrent UTIs and enteric bacteria culturing from her vagina, but the MRI and CT are not finding a fistula, what would you try? Assuming vaginal estrogen is on the list, but any other approaches you can share? Thank you.
Okay. And I know the question said postmenopausal with a suspected fistula, although MRI imaging was negative. So I have to assume then that other imaging was also negative. I mean, my next step would always include a cystoscopy to confirm there's no vesicovaginal fistula, but perhaps also a colonoscopy, right, to confirm no fistulous connection there. So assuming that those are also normal and negative, I have to agree that there's no fistula. So if we've looked in all three holes, imaging in all three holes, including that MRI is negative, let's just say it's not a fistula, but having enterococcus or bowel-based bacteria is just common. And I think going over the big four, so diet, perineal hygiene, and behavioral modifications, definitely estrogen cream in the postmenopausal woman, regardless of her breast cancer status. And then UTIVA every day and some physical therapy. That's really the way to go. Again, these questions are amazing, but we all have to remember our basics and the big four key points, and reminding our patient of the ways to prevent these. Sometimes they're conservative, but in our own hands.
So my urologist told me that standard cranberry capsules, 500 milligrams, twice a day were as good as taking UTIVA.
So 500 milligrams twice a day, D-mannose, you said?
No, just a standard cranberry capsule.
Oh, sorry, cranberry.
Yeah.
So I would disagree. I would disagree for all the elements that we reviewed in the slides just a few moments ago. What are the additives in a standard capsule? For example, vitamin K that could influence a woman who's on blood thinners already. So I think it's just overall safer. And the research has proven that the UTIVA PACs are more effective. And I know your team's going to go over that in a moment, so I don't want to belabor the point. I know you'll have the Cochrane review that recently came out, sort of summarizing some of this data. And I think it's important that y'all bring that up to help answer this question in a moment.
So another question on UTIVA. I had a patient try the UTIVA product and she reported that it made her symptoms worse. What would you say to this?
So great question. Obviously, I need more information. So her symptoms, because that's what the question said, symptoms. Symptoms could be urgency and frequency. And I don't, I can't think of a reason why UTIVA would make those worse, except that they may not have helped her if the urgency and frequency are from an overactive bladder or that bladder pain syndrome, which is what we used to call interstitial cystitis. So a lot of women with these two medical diagnoses are misdiagnosed as having recurrent urinary tract infections for several reasons. We don't get cultures to prove it. We just assume the woman knows she has a UTI, and we just say, do this and take a UTIVA and have your antibiotics when you want them, and no firm diagnosis has been made. So without that information, I have to assume that this particular patient doesn't really have recurrent UTIs. So the UTIVA hasn't helped her. And that's maybe why she feels like her symptoms are worse, because she has a natural progression of a different diagnosis altogether.
Interesting. It's a good way to think about it. So do you recommend patients take estrogen cream nightly? I thought it was 2 nights per week for dosing.
Yes. So the pharmacist is always going to say that, because the research for brands like Premarin and Estrase were based on that sort of information when it's dispensed. So whoever asked the question, you are correct. The research was based on that for FDA clearance in America. But I see far better results just observationally, or with my expert opinion, when patients use a dollop on their fingertip every single night, directly applied to the vaginal introitus where the urethral meatus is. Another thing that y'all should be mindful of is, tonight we're talking about practical things, right? So just practically telling patient, what is the diagnosis? What are the big four reasons? How can you, the patient, mitigate these big four reasons yourself? And so another practical tip, y'all, is that a lot of our women are like me. We're busy moms. I can barely remember what my kids are supposed to pack in their lunchbox for tomorrow and what uniform they have to wear. So I'm not going to remember to put estrogen cream on every Monday and third Thursday of the week. You know what I mean? So for me, it's just a matter of, it's more effective if you use it nightly. And the woman, the patient, will remember it. We brush our teeth every night. We pee every night. We wash our face every night. So just do the cream every night, and you'll get better compliance with your patients. And that's practical.
Very smart. Yeah, that makes sense, right? Twice a week. Who's going to remember that? Yeah.
Nobody. So just put it next to your toothpaste. I have confused them before, and estrogen cream does not taste very good. And my vagina was on fire from the minty fresh toothpaste. But I think it's a good way to remember it. Just do it nightly. Absolutely. Better compliance, which leads to better outcomes for our patients.
Let's do another 5 minutes for anyone who's open to staying on. We'll run through some more questions for 5 minutes. Is that okay with you, Dr. Oakley?
Absolutely. Let's do it.
Okay. So next question. Many people do not have immediate access to labs and to doctors, especially in rural and remote areas. How do we manage them if I can't get some to a lab for at least 3 days? Example, I get a patient late Friday afternoon and no lab until next Monday. They have fever, chills, right, like flank pressure, cloudy, smelly urine, and dysphoria. What would you suggest?
Great question. I get this call all the time. There are only two of us, so we are always on call. And it always happens on a Friday, right? You're about to close your door and the patient calls, and I think, Barb, you knew you had these symptoms yesterday. You could have come in. But we still are very firm in our practice. My partner and I agree that those patients should go to the nearest urgent care. We are lucky that we have several urgent cares that are open late, so the patient doesn't have to wait in an emergency room. And so this answer may not be applicable to the person who asked, and I apologize, but we do still want a culture. So we send them to urgent care. If urgent care confirms red flag symptoms with the flank pain or fever, hematuria, they can always do a quick x-ray or imaging there in urgent care to rule out a stone or other potential worse issue. This sounds like a complicated UTI, but I still would refrain from empiric treatment, in all honesty. I think if you really are, as in my work as a mission doctor, in an area where you can't even send them to urgent care and there's no emergency room close by, and you have the old Dollar Tree dipstick in the office, and the nights, are positive and the Lukes are positive, and you really are concerned about the cloudiness and the red flag symptoms, I think, barring any allergies to nitrofurantoin, it is reasonable at that time to administer an empiric antibiotic prescription with macrobid or nitrofurantoin. giving them the specific precautions that should their fever worsen, that they should call for an ambulance if they're in an area where they don't have access to urgent care or an ER that they can get to safely. So yeah, great question. Difficult situation.
Yeah, for sure. So this question came up a few times. What is it in the tea that can increase the risk of UTI? What about herbal tea? Is it simply that the body's getting dehydrated because of the caffeine content?
Yeah, I mean, yes to all the above. And I love whoever submitted this question, because I always joke that this is why mama has to have her wine at night, because I have PTSD from dealing with women all day. So all women want to do with me is barter and bargain about the darn diet, And so, yeah, before answering the question, just be strict with your patients. Dilution is always the solution to pollution. Water, water, water. I'm a gardener and I will never get my garden to grow if I pour tea on it. That's not how my tomatoes grow. It's because I give them water and I give them just enough. Another thing I like to joke around with my patients, regardless of religious beliefs tonight, I always say, Jesus had water. So drink your water, right? Jesus didn't have, Coca-Cola. But all jokes aside, we are worried about caffeine, and even herbal tea can have caffeine in it. You cannot squeeze the caffeine out of a tea leaf. You cannot squeeze the caffeine out of a coffee bean. And so these sorts of decaf versions of things tend to still have a little caffeine in them, but we're also worried about carbonation. There are a lot of trendy refresher teas out there, whether you buy them at a chain or at the store. So carbonation, bubbles, caffeine, anything. And we can't lie to ourselves. We all have a tendency to add just a little bit of something, right? A little bit of cream, which has sugar, or a little bit of fake sugar, a little bit of stevia, a little bit of Splenda, or whatever it is to our drinks. And those are also irritants to the bladder. So for all those reasons, just remember my rule earlier, y'all. If you wouldn't give it to your baby child, why would you give it to you? And as a mother, I have never given my children anything but water or milk. They do not get coffee, tea, or soda, ever. And I know they will one day. Not right now.
You're gonna try to protect them from it as long as you possibly can.
They'll do whatever they want at the age of 18, and we all know it, right?
Yeah. Let's do two more. Let's do two more questions. So,
okay.
Are there no recommendations for cephalexin for UTIs? In Canada, it is still listed to use.
It's a great question. And I'm sorry to be fully unaware and an absolute idiot about the Canadian recommendations. It's not listed in America, although it is ubiquitous, right? It is inexpensive, readily available in the United States at every pharmacy. And a lot of our primary care providers do prescribe it, whether mostly I would say empirically, to treat urinary tract infections in the office setting. So I see no problem with that. I think my main point tonight is just to make sure we have an appropriate diagnosis, which is based on a culture. And if you have a culture proving the bacteria type, then that culture also will show you the sensitivities and susceptibilities. And it is still recommended to start with nitrofurantoin first. Followed by sulfa-based antibiotics. I think the third line recommendation in America is still fosfomycin or Monurol as a brand. But that can be very expensive. So at that point, I see no problem using cephalexin or Keflex or other ones like Augmentin, amoxicillin, if the culture susceptibilities prove that that particular bacteria is treatable by that specific antibiotic you want to use.
Okay, awesome. And then I'm going to just ask you this final question. It was a follow-up to your rural the question about a rural patient in a rural setting. So here Anthony is asking, how do you deal with a UTI in a mission field? I'm guessing whether you do the diagnosis and send the patient to the local hospital, or do you bring some nitrofurantoin or Septra and send them away with the antibiotic? What is the challenges on the mission field that you face as a missionary doctor?
Everything you can think of, right? They've walked miles to come see me in an office where I have very meager laboratory tools to assess it. So it is based typically for me on symptoms alone. So now you're going to have to ignore everything I said up to this point. But when I really am in that sort of underdeveloped area of the world, I have to base it on symptoms alone, use my clinical acumen and intuition, and I have to utilize whatever antibiotic I have available. And sometimes it may not be anything I have said tonight. So I find that I can get sulfa or Cipro fairly readily in other countries, but it may just be a simple amoxicillin or even sometimes just azithromycin in these other countries. And so I have to use what is there and what is available and base it on symptoms alone. So great question, but that's when I'm what I call MacGyver it. And half of y'all are probably too young to know who MacGyver is, but
I've heard of him. Not that young. Dr. Oakley, I just wanted to thank you so much for your time. There's been tons of comments in the chat of people saying they've enjoyed the talk as well. And I just wanted to, is there anything else you wanna say before we go?
no, I think y'all have been a wonderful audience, and I really appreciate you, Tiva, for the opportunity to speak tonight. Thank you for your time and your attention. I know it's a late night, depending on where you are in the world. And again, sorry that my statistics were mostly around the United States, something I can improve on next time we meet and talk. But if there are any other lingering questions, I'm sure UTIVA will forward them to me, and we'll figure out a way to get some answers out there for y'all. And again, I appreciate everyone's time and attention, and thanks, UTIVA. And y'all have a wonderful night. Good luck to the winners of the raffle. Hopefully, yeah, some big winners tonight. I'm jealous.
Sorry we couldn't add you, but
I know, I really am mad about that. But everyone have a wonderful night, a happy fall, y'all. And thanks again for the opportunity. Thanks for your time and attention.
Of course. Have a good night.